Thank you very much, Anna, for the kind introduction. I hope everybody can see my screen well now. I may be a little an outlier in this trauma care series, as my daily practice is not in the UK, but in the Netherlands, where I work as an emergency physician in the University Hospital Medical Center in Groningen, up north in the country. But beside my work as an emergency physician there, I also am employed by the Surrey and Sussex Airambulance in the UK. And I am an alumnus of the Londons Airambulance, where I worked in 2020-21. And that is where the work we will be talking about tonight kind of originated. So the plan for tonight is that in the next 30 or 40 minutes or so, I will share with you some thoughts about advanced treatment options for patients with penetrating injuries, and talk also a little bit about pathophysiology on the way, because I think that's really important to understand how we should treat these patients. I will mainly, but not only, be talking about this paper that was published last year in Critical Care. So technically, it's not really hot at the press anymore, but it's still a quite hot topic, I think. And before I start talking about the paper itself, I would like to say a huge thank you to all colleagues from various air ambulances in the UK and also abroad who supported me in this work, and also to my colleagues from LAA and KSS, who were not listed on the paper as co-authors, but who shared their knowledge and experiences with me over the years. I think the in-depth discussions we had about physiology and treatment options hugely contributed to the content of this paper. And last but not least, I want to say a special thank you to Carl Evans, who's a resident in emergency medicine in Brighton and Sussex University Trust Hospitals now, who allowed me to share with you some data from his master's thesis tonight to illustrate some of the concepts we will be talking about. Right, having said that, penetrating injuries, sadly enough, when you open the newspapers, it is not unusual to see headlines and scenes like this. They had become almost business as usual. And that is not only in the UK, but also in my home country in the Netherlands. For many years, blunt injuries were almost the only trauma presentation in the Netherlands, but also in the Netherlands, the years of windmill-related accidents have long gone. And this is a screenshot from earlier this week, and it shows that we are sadly catching up on penetrating injuries in our country as well. And it is a big problem, and it is a growing problem as well. And this is a graph that I took from a paper that was published by the group of Mark Foster from 2020, when penetrating knife injury presentations in a single MTC in Birmingham are represented. And you can see the line is slowly creeping up over the years from 2015 to 2018. And that is not unique for Birmingham, and that is seen throughout the UK. It is seen throughout Europe, and even in Nordic countries like peaceful Sweden, we see that there's a trend in increasing penetrating injuries, as you can see a graph I took from an article that was published a few years ago. But you can see the number of step wounds and gunshot wounds represented over the years of patients who are presented in a trauma center with an ISS over 15. And you see the similar trend there, as you can see in the UK. And to a certain extent, interestingly, these injuries have almost become predictable. What you see here is a heat map of penetrating injuries in the southeast of England that was taken from a publication from the Surrey and Sussex Airambulance from a few years ago. And as you can see, the distribution of the HEMS jobs in the red color nicely follows the drug trafficking county lines. So we kind of know where it will happen. And we also almost know when it will happen. This is a graph taken from an article that was published in Trauma, Surgery and Acute Care Open from a few years ago. And it shows actually it was last year, I think. It's just a diurnal variation in the gluteal stabbings, which seems to be a new trend in London over the last few years. And it clearly demonstrates that people go out to be stabbed either in the late afternoon or the early evening when the schools have finished, or around midnight. Well, luckily, there is a solution to the rising incidence in penetrating injuries. A research group from King's College in London has investigated the impact of the strict lockdowns during the COVID times on penetrating injuries, and there was a good effect on the number of penetrating injuries presented in the trauma center. So essentially, we just have to wait for the next pandemic. And yeah, of course, this is a bit a cynical joke, because we are faced with a significant and growing problem. And although the topic of my talk today is about treatment, especially about advanced treatment for penetrating injury, I think we should never forget the impact preventive measures may have as well. And I think also as medical professionals, as we are here tonight together, we should keep that in mind, and we should contribute to preventive measures wherever we can. And there's one initiative I want to mention in that respect that I came across when I worked in London, and that's the Your Sense organization. Your Sense organizes workshops that are specifically targeted to areas of high youth violence and to young people that are vulnerable to serious youth violence, either to be exposed to it or to witness it. And they teach these people ages between 11 and 25 how to perform cardiopulmonary resuscitation and hemorrhage control following serious incidents of violence. And I have no stocks whatsoever in this initiative, but I think it is a brilliant initiative that can save many, many lives. Before I want to shift the focus from epidemiology and prevention to actual treatment of penetrating injuries, I think it is important to clarify that tonight I will only be talking about the treatment of sharp object penetrating injuries, as opposed to gunshot wound-related penetrating injuries that are far more frequent in countries like the like the US. And it is important to note that, as you all know, the energy transferred by a knife is completely different and much lower than the energy transferred by a high-velocity bullet from a rifle or from a shotgun. The higher energy of a bullet creates far more tissue damage and cavitation, which has important treatment consequences. So from now on, when I talk about penetrating injuries, I refer to sharp object penetrating injuries rather than ballistic injuries. My presentation tonight will be about advanced treatment options for patients who are exsanguinating from penetrating injuries. But luckily, the vast majority of patients don't need these advanced treatment options. Most of the patients who suffer from penetrating injuries can be treated with relatively simple measures in the prehospital setting. Stopping the bleed, of course, is key, and hemorrhage control can be gained by simple measures such as direct pressure or the application of a tourniquet. And once control is gained, the COMA acronym can be a really nice way to remember further treatment in the prehospital setting. It stands for clothing off, oxygen, monitoring, and access. And if we talk about clothing off, we mean fully exposing the patient, which is really important because many patients are anxious, they're stressed, they're excited, and they often don't register where they are injured. And they focus quite often on the most obvious injury, which may not be the most clinically relevant injury to treat. Oxygen, of course, especially when chest injuries with respiratory distress are present, and monitoring and access. And access is really important to establish early because, as we come to speak of later, many of these patients deteriorate quite rapidly. And when you're there as a first EMS resource, being able to get the access can be super important for further treatment later on. And of course, as you see at the bottom of the slide, and I can't emphasize that enough tonight, minimizing scene time, because no definitive treatments can be offered for these patients on scene, and we have to transfer them to appropriate in-hospital care as soon as we can. In some patients, however, we cannot control the bleed, and we can't either in the pre-hospital setting nor in the ED. And a significant proportion of these patients will die early after the injury if we do nothing. As you can see in this graph that I took from a paper published by Karim Broey and John Holcomb a couple of years ago. What you see here represented is a time distribution of mortality of patients who activated a major hemorrhage protocol in an MTC. And as you can see, over the years between 2009 and 2015, in only 6 years' time, we have been able to reduce pre-hospital mortality significantly. However, the drop in pre-hospital mortality shifted mortality towards the in-hospital phase of treatment, as you can see in the 0 to 3 hour interval. And although we have been able to get a 25% reduction in mortality over the years, overall mortality, and we are getting better, we still have a significant proportion of almost 25% of these patients who die in the pre-hospital setting. And to be able to understand how we can potentially treat these patients, I think we must understand why these patients are dying. So we dive a little bit deeper into that. What you can see here is a bar diagram of unpublished data from 55 consecutive patients with penetrating injuries to whom London's Airambulance was dispatched, but who had already passed away before the team arrived. And take note of that. The average time from 999 call to patient side is around 20 minutes in London. So these patients had died within 20 minutes of their injury. And a reasonable number, almost 40%, as you might have expected, had primary cardiac injuries. But even more patients, as you can see here, died from major arterial injuries. So then the question arises, how exactly do you die from arterial injuries? And this is a picture from the HLS manual most of you have been brought up with, and you will all recognize. Represented are the increasing classes of shock, from a class 1, representing a mild shock, to a class 4, a severe shock. And with increasing shock class, there's an increasing amount of blood loss, tachycardia, lower blood pressures. And in the end, there's no blood left to circulate, and the blood pressure drops, and vital organs don't get perfused, and ultimately patients die from hypovolemic shock. But this is not the whole picture in patients with arterial injuries. Something else is going on as well in these patients, and it is something that is really important to understand when we come to speak about the treatment options for these patients later. And I will try to show you what I think it is. To understand that, we have to look at the physiology of the arterial wind castle or the aortic wind castle. Under normal circumstances, the aorta and the other elastic arteries convert a pulsatile blood flow into a continuous blood flow, just like the principle of how a water tower works. As you can see in the figure on the right side of the screen. During systole, an amount of blood is injected in the aorta, and the elastic arterial stretch of the wall kind of stores the potential energy. And then during diastole, the elastic recoil generates diastolic blood pressures. But what happens when there is a hole in the aorta or its first or second main branches? In that case, it's logical that the blood follows the way of the least resistance, and outflow is larger than inflow. And this becomes the pressure reservoir to become charged during systole. So no potential energy is stored, and hence there will be no recoil during the diastole. And therefore, during diastole, the diastolic blood pressures cannot be generated, and diastolic blood pressures are really low. And this has important consequences as the coronary arteries are mainly perfused during diastole, so coronary perfusion will be really low. And this is a concept for secondary cardiac injury. And do we have evidence for such an arterial shock for secondary cardiac injury as a result from blood loss? I think the answer is yes. We have what the police would call a lot of circumstantial evidence supporting this hypothesis. First, we can have a look at simple blood pressure tracings. If you look at the left, you see a classic hemorrhagic shock blood pressure tracing of a patient who has a pelvic fracture. And you note that the pulse pressure is really narrow as a result of profound vasoconstriction to preserve diastolic blood pressure and coronary perfusion. On the right are similar blood pressure readings, but then from a patient with penetrating injury to the iliac artery. And although he's able to compensate and maintain systolic blood pressures, as most of these patients are young and healthy, diastolic blood pressures hit very low values for the reasons I just discussed. We can also look at cardiac biomarkers. Hard-type fatty acid binding protein is a protein released from the myocardium in response to myocardial injury. And it's analog to troponin T and troponin I, but it's more sensitive. And as part of the ITACTIC trial, investigating the merit of viscoelastic hemostatic assay augmented protocols for major trauma hemorrhage, blood samples were collected from around 140 patients presenting with a hemorrhagic shock in the ED of the Royal London Hospital. And in these patients, hard-type fatty acid binding protein levels were measured and compared to control patients without a shock. And what you see here is for 3 timestamps at presentation, 24 hours and 72 hours after presentation, the levels represented on the y-axis. And you can see that patients with a classic hemorrhagic shock have, at least at presentation after 24 hours, elevated levels of the hard-type fatty acid binding protein. But patients who have an arterial shock have much higher levels compared to patients who have a classic hemorrhagic shock time. And this, I think, indicates a larger extent of myocardial injury. So it is likely that the pathophysiology of shock in many patients with non-compressible penetrating injuries extends beyond volume loss and is an interplay between volume loss and the disruption of the arterial pressure reservoir. When you lose blood volume, your preload is decreased, your stroke volume is decreased, you got a lower systolic blood pressure, and at the same time, disruption of the pressure reservoir, as we just saw, decreases peripheral resistance, creates a low diastolic pressure with reduced coronary perfusion and secondary cardiac injury. And together, this creates an accelerated deterioration of these patients. So as these 2 processes are both important, treatment of patients exsanguinating from non-compressible hemorrhage should ideally be aimed at both these processes as well. So our treatment goals in these patients should be in line with that. We should not only restore blood volume and oxygen carrying capacity at the earliest possible moment, but we should also aim to stop the bleed and resuscitate the heart. And the exact treatment options we have to achieve this latter goal are largely dependent on the localization of the injuries, in particular if they are located above or below the diaphragm. Let's first have a look at injuries above the diaphragm. For these injuries, resuscitative thoracotomy can be performed to stop the bleed and resuscitate the heart. If you open the chest, it offers the opportunity to explore and treat injuries, and this is easiest when the thoracic cavity is fully exposed. And therefore, a clamshell technique, especially in the prehospital setting, is often the preferred way of opening the chest. It is a bit beyond the scope of this presentation tonight to go into detail about all the steps of how to perform a clamshell thoracotomy, especially as there's excellent literature around there to read about this. And there's one article in particular I can highly recommend, even though it's published almost 20 years ago in EMG. I think it's still actual and still really nicely describes all the steps of the clamshell thoracotomy procedure. So I've attached a QR code later on to scan if you want to reread that. One of the key steps, as you can see here, is compressing or clamping of the descending aorta. And the purpose of it is that we want to increase the afterload to the heart and hence increase diastolic coronary perfusion pressures. And this may increase chances of ROSC when at the same time cardiac massage is provided and blood products are administered. We need all of that, not just the clamping, not just the massage, not just the blood product, we need all of it. For penetrating injuries below the diaphragm, it is a little bit more difficult and multiple treatment options exist. A thoracotomy can still be considered with the aim of occluding the descending aorta as a somewhat controversial pre-laparotomy last-ditch rescue maneuver. The literature on the efficacy of this procedure for this particular indication for subdiaphragmatic bleedings is quite sparse. And this review from 2020 mentions a considerable variation in the survival between various studies, with obviously a clear benefit when a thoracotomy was performed early, even in the pre-arrest phase. An alternative to thoracotomy for these patients with injury below the diaphragm might be REBOA, standing for Resuscitative endovascular balloon occlusion of the aorta. And the principle of REBOA is relatively simple. The catheter with an inflatable balloon is inserted by an 8-French sheath that is placed in the common femoral artery, and the balloon can then be inflated in 2 different zones depending on the anatomical location of the injuries. It can be either in zone 1, as you see on the top left, which is above the celiac artery, or in zone 3, which is below the lowest renal artery. And the balloon inflation of a REBOA creates the same afterload increase as they're obtained by clamping the aorta. And for this indication, a REBOA is now used both in hospital but also in pre-hospital setting by several services, and case studies so far have shown quite good results. To illustrate the effects of REBOA on afterload, I have 2 examples here of invasive blood pressure readings of patients attended who received a zone 1 REBOA in a pre-hospital setting. So with balloon inflation above the celiac artery. And as you can see, pre-balloon inflation, diastolic blood pressures were really, really low. And inflating the balloon instantly increases these pressures, and together with volume depletion result in re-establishing blood pressures that meet coronary perfusion requirement quite quickly after inflation. However, both REBOA and thoracotomy, of course, may have serious side effects and may result in significant comorbidity. So the million-dollar question is, who qualifies for these interventions? And this may be a little bit unusual picture. I'm not a botanist, but when the leaves of my plants at home look a bit wrinkled and the soil looks a bit dry, I give them water first and reevaluate later. And the same is true for our patient. When they respond to volume, they probably don't need a REBOA or a thoracotomy as a bridge to definitive therapy. On the other extreme, when the roots of your plant at home have died, you can water them whatever you want and give them a complicated mixture of nutrients, but they will never recover. And the same is true with our patients. So we have to find the right patients to perform these treatments. And the patients who are likely to benefit most from the advanced procedures we just talked about, I think fall in 2 broad categories. These are patients presenting in extremis or patients with a viable traumatic cardiac arrest. So I would like to zoom in a bit more on these 2 groups in the rest of my presentation. First, patients in extremis after non-compressible penetrating injuries. What defines a patient in extremis? That in itself, I think, is a very hard question to answer. And I still don't have the answer myself. And I think this is highly controversial to describe what a patient in extremis is. We all agree these are not patients who are a little hypotensive or slightly tachycardic or a little unwell. These are patients who are at the brink of arresting due to their injuries. And if we do nothing, they arrest in the next few minutes. But from my own experience, I can tell you, I find it really hard, and I've struggled on many occasions to determine if that really was the case. Discerning this small group of patients who may benefit from these procedures amongst a large group of patients with penetrating injuries can be a huge challenge, and especially in the pre-hospital setting. There's no clinical factor in isolation that can reliably define or predict exsanguinating hemorrhage, and prediction risk models that are used in hospitals are often useless in the field because they're too complicated. So I think clinicians should have a high degree of suspicion when there is a mechanism of injury that is compatible with major vascular disruption, especially when shock is present immediately after the injury and a constellation of clinical signs is present, such as paleness, diaphoresis, air hunger, venous collapse, a low or falling and tidal, and tachybradycardia or reduced level of consciousness. Not all of these have to be present, but quite often quite a few of them are present. But I realized this is not hard science, and this is more expert opinion. And I really hope that in the future, data-driven AI models may help us to identify these patients better and quicker, so that we can provide appropriate treatments to the patients who need it, and not perform these potentially harmful procedures in patients who don't need them. Once we have identified a patient in extremis due to penetrating injuries, there are three things we have to do. We have to occlude and treat obstructive causes of shock. We have to provide volume resuscitation, and we have to provide cardiac resuscitation and hemorrhage control. Excluding existence of a tension pneumothorax or tamponade is important, as it may change or influence our treatment plan, especially when injuries are in the flank and the epigastrium. A patient with a tension pneumothorax may just need thoracostomies at no further advanced treatment. Whereas in a patient with a flank or epigastrial penetrating injury, both cavities may be involved, which may influence the decision around whether we should perform a thoracotomy or a Ebola, as we will come to see later. And I think a useful tool also in a pre-hospital setting to make a quick diagnosis and a quick to determine if any obstructive cause of shock are present is because of ultrasonography. As mentioned, once we have established that the patient is suffering from exsanguination, he or she needs volume resuscitation. We've established an indication, but we don't have a really good endpoint to head for. Because the ultimate endpoint of volume resuscitation is adequate coronary perfusion, but there's no easy way to measure this in a pre-hospital setting. And therefore, we use various pragmatic surrogates and endpoints that are often used in conjunction, as consciousness, the presence of palpable pulses, entitles, diastolic blood pressures, or the absence of ischemia on the ECG. Although a degree of hypotension is often accepted and beneficial effects of outcome have been reported for permissive hypotension, I think it is good to keep in mind that the reported beneficial effects of permissive hypotension may not only be due to the accepted lower blood pressures, but also to crystalloid restriction. And the theory behind permissive hypotension is that it allows clot formation and prevents clot dislodgement by reducing the blood pressure gradient at the site of the injury, and also by mitigating the creation of dilutional coagulopathy. And especially the first process may be more effective in patients with small vessel bleeding rather than those with major arterial bleeding from penetrating injuries. If we have established an indication and we start treating the patient with blood products, these should be administered in a 1-to-1 ratio or as whole blood, such as done by several ambulance services right now in the UK as part of the SWIFT trial. And last, if we treat, we also have to monitor a response. And the response to volume resuscitation should be monitored closely. Patients with hemorrhagic shock often demonstrate large variation in non-invasive blood pressure readings, and automatic non-invasive readings tend to overestimate blood pressures generally. So if an arterial line is in place, we can use it for really good blood pressure monitoring. If it is placed in the femoral artery, it has the additional benefit that we can not only use it for blood pressure monitoring, but also for potentially upscaling to an 8 French sheet for a potential Reboa in case the patient is not responsive to blood products. And last but not least, after excluding obstructive shock causes, providing volume resuscitation, we have at the same time to provide cardiac resuscitation hemorrhage control in patients in extremis. And as I mentioned before, there's 2 options. These can be achieved both by thoracotomy and by Reboa. And a thoracotomy can be considered even when the patient is not yet fully arrested for thoracic injuries, especially when a tamponade has been identified. For subdiaphragmatic injuries, thoracotomy is often a last-ditch effort, and previous studies, such as this one published in the Journal of American College of Surgery, have demonstrated that Reboa may be a good alternative with a higher odds ratio of survival than thoracotomy. If we have decided that Reboa is the treatment we go for, we have to determine the appropriate zone for Reboa, either zone 1 or zone 3. And that is largely based on anatomical location of the injuries and also on presenting physiology. Generally, penetrating injuries in the upper thigh, in the groin, or the buttock are amenable to zone 3 Reboa, whereas for abdominal and flank penetrating injuries, the balloon has to be deployed in zone 1. When patients are about to arrest, though, when they're really bradycardic, when they demonstrate a really low filing and tidal CO2, despite all other resuscitative efforts, a zone 1 Reboa provides a higher afterload augmentation in the zone 3 and may therefore be preferable in these circumstances, even when the injury is in the thigh or the buttock or the groin. And then at a later time, the balloon can either be deflated and repositioned to a zone 3 or partially deflated if hemodynamics allow that. We all know that emergency anesthesia of hypotensive trauma patients carries a significant risk, and this is also true for trauma patients with penetrating injuries. It's not different. This is related both to the effect of induction agents on an already compromised preload, they lost a lot of blood, and then aggravated by the subsequent positive pressure ventilation. And therefore, where possible, we should try to avoid prehospital anesthesia in these patients and should delay it until immediate definitive hemorrhage control is also available. And if you really, really have to do it, for example, due to an actual or impeding airway obstruction or ventilatory failure, we have to be careful and choose hemodynamically stable induction agents with a short half-life, such as ketamine, and really, really reduce our dosages that we use. So we have talked about patients in extremis, but what about patients who have already arrested? How should we treat these patients? What you see here is the current ERC guideline for traumatic cardiac arrest and the peri-arrest algorithm. And if you look closely under 4 and 5, it mentions Reboa and thoracotomy. It suggests that both Reboa and thoracotomy can be considered to facilitate cardiac resuscitation in patients with a TCA. But what it doesn't tell you is when exactly you should embark on this journey and which modality to choose. The decision whether or not to proceed with thoracotomy or Reboa depends not only on available resources and training, but also on injury pattern and the time elapsed from injury. And as you can see here, the ESC guideline and other guidelines as well suggest to consider thoracotomy when other reversible causes have been addressed and a maximum of 10 to 15 minutes has been elapsed since vital signs were lost. However, the evidence supporting this 10 to 15 minute cutoff is quite weak. And I think time should be considered only as a general guidance. And to illustrate it, I want to show you this picture, which you have to credit Dr. Zane Perkins, who presented this based on data from London's Airambulance at the London Trauma Conference last December. In general, patients with a prolonged period of cardiac arrest are unlikely to benefit from advanced invasive pre-hospital interventions such as a thoracotomy. Patients who have already exsanguinated and are in a cardiac arrest with an asystole or a wide complex disorganized rhythm have an extremely poor prognosis, and any procedures in these patients are likely futile. On the other hand, patients who have a low flow state with an organized narrow complex rhythm and a relatively high end tidal CO2 may have the potential for a good outcome and warrant ongoing aggressive resuscitation attempts. So looking at the cardiac rhythm can help decision-making as the rhythm deteriorates in a time-dependent manner, as you can see in this graph. And this is very helpful. As many of you will know, it is often very hard to establish an accurate timeline straight after arrival on scene in these patients. What these data also show is that deterioration goes rapidly. Rapid deterioration from a sinus rhythm to a sinus bradycardia to an agonal rhythm and an asystole happens in 5 to 10 minutes. And therefore, decision-making on scene about advanced treatment should continue in an efficient manner. It should be quick, and no monitoring should be applied for reasons of decision-making. Similar is for ultrasound. If you have a potential perfusing rhythm, like a sinus rhythm or a sinus tachy, an ultrasound should not be performed to support decision-making, rather for these advanced procedures. Once decided that the patient qualifies for aggressive resuscitation with advanced therapeutic procedures, the choice for a thoracotomy or Reboa in patients who have already arrested largely depends on the anatomical site of the injury, as we discussed before, for patient in extremis. When patients suffer from isolated penetrating injury to the chest resulting in a traumatic cardiac arrest, thoracotomy offers the opportunity to relieve a tamponade and to obtain hemorrhage control by direct treatment of intrathoracic injuries. And you can think about suturing wounds at the heart, as you can see on the right. You can think about treating lung injuries by performing a highlight twist or a highlight clamp or a highlight occlusion, or relieving a tamponade, of course. Again, as with patient extremes, optimal treatment for patients with subdiaphragmatic injuries who are in cardiac arrest is less well established. As I mentioned before, although controversial and a last-ditch effort, a thoracotomy can be performed in these patients with the aim of cross-clamping the aorta only. It may be considered in arrested patients with penetrating abdominal flank or groin trauma. With a zone 1 Reboa with placement of the balloon at the level of the diaphragm is less invasive and has the additional advantage over thoracotomy that a partial Reboa can be initiated after the initial resuscitation phase. Although pre-hospital studies show favorable results in terms of ROS rates, and similar favorable results of ROS rates have been observed in trials where Reboa was used for medical cardiac arrest, such as the Reboa arrest trial that is currently running in Scandinavia. These results are promising, and pre-hospital studies that are currently being conducted or have just finished as the P-Pro study in London may hopefully provide more information about the feasibility of zone 1 Reboa for this indication in the pre-hospital setting. It gets particularly complicated with epigastric injuries, as I already touched on before, as they are at the junction of the abdominal and the thoracic cavity. And in these instances, rapid focus in addition to clinical assessment can help the pre-hospital clinician to decide whether to proceed either with thoracotomy or with Reboa. If a tamponade or large pleural effusion is detected, thoracotomy is to be considered, whereas in the absence of these, the abdominal injury is more likely the cause of the hypovolemic arrest, and a Reboa may be used. I want to spend a few words now on cardiac massage and adrenaline in traumatic cardiac arrest in patients with penetrating injuries. As many people ask me if external cardiac massage should be offered during traumatic cardiac arrest in general. And I think there's not much harm when no other procedures are carried out, but equally the benefit will likely be small as well, because the cardiac output generated by external cardiac compressions relies on passive filling of the heart during the recall phase after each compression. And during traumatic causes of cardiac arrest, such as exsanguination, tamponade, or tension pneumothorax, the preload and diastolic ventricular filling are significantly reduced, and hence the ejection fraction during CPR, which is maximum around 30% in euvolemic individuals, is likely to be very, very low. There is an exemption to this rule, though, which is important when we talk about patients with penetrating injuries, and that are patients who are in cardiac arrest from subdiaphragmatic exsanguination, in whom a Reboa is performed. And following balloon inflation, reduction in blood loss may allow ventricular filling, and when combined with external cardiac massage, results in an increase in coronary perfusion pressures and myocardial oxygen delivery. Equally, when we talk about adrenaline, standard resuscitation dose of adrenaline at fixed intervals, I think, should be avoided, as no survival benefit has been demonstrated in patients with hypovolemic cardiac arrest. But small aliquots of adrenaline may be considered to restart the heart if not successful with filling and massage and flicking the heart alone. And then we get to talk about post-ROSC care. Once ROSC is obtained, our treatment, of course, is not finished. We have occluded the aorta with a clamp or a balloon, and it is important that distal perfusion should be restored as soon as possible, as prolonged complete aortic occlusion is unsurvivable due to distal ischemia created. When a Reboa balloon is deployed, titrated balloon deflation, a technique called P-Reboa, partial Reboa, can be introduced at that stage. And it usually commands 10 to 20 minutes after balloon inflation if the patient hemodynamics make it feasible. And it's good to remember that that point will usually be reached already during transport to hospital. So in the pre-hospital phase, there are already attempts to deflate a balloon to increase peripheral perfusion if blood pressures allow. In some patients, Reboa increases blood pressure to such an extent that the level of consciousness increases, and these patients start to get awake. And then, of course, they require sedation and analgesia as well. And last but not least, I have said it before, but it's super important, rapid transfer to definitive care is always warranted, as no definitive treatment can be provided in the pre-hospital setting. And everything we do is just a bridge to definitive care. So bringing this all together, I hope that the next ERC guidelines, to be written in a few years from now, will provide more specific guidance on when to use advanced procedures as Reboa and thoracotomy for patients in extremis or in cardiac arrest who have sustained penetrating injuries. And if you ask me, based on the article we've written and what I told you tonight, this may look a little bit like what you see here on the right side of the screen. That's it for me. Thank you very much for your attention, and I'm, of course, very happy to take any questions if there are any. Thank you.
Brilliant. Thank you so much, Dr. Avest. Thank you so much for that. Such a succinct and well thought out paper and accompaniment to it as well with your webinar. So as usual, everybody, I'm just going to get up the Q&A page. So everyone who would like to can scan the QR code that you see in front of you here. This QR code will take you through to be able to purchase your CPD certificate if you are not a member of Trauma Care. Now, if you sign up within the next sort of day or so, don't worry, you will still get a free certificate for attending tonight. So don't go and rush to buy a certificate and then go, actually, I'm going to sign up. If you want to sign up instead, you'll still be eligible for a free CPD certificate until the moment Emma does send them out to you. However, if you don't want to become a member of Trauma Care and this was a one-off for you because you are so interested in this research paper, please do scan the QR code that's on your screen now. It will take you back to the reflective feed, the reflective form where you can fill it in and get your certificate for £1.99 with all the money going back to charity so we can continue to do things like this. Now, this is your opportunity as well to bring some questions in. So the question and Q&A box is open. I'm just going to keep the chat open as well, just in case anyone pops them in there. However, as always, it's not a guarantee that we're going to get questions, especially with a presentation so succinct and so thorough as this. Sometimes we don't get any coming in. So I'll leave the Q&As open for a couple of minutes, and then if anyone has anything, please do pop them in now. Now is your chance to do it, or scan the QR code that's on your screen now. However, people are just putting that they've learned a lot tonight, so I think it was so thoroughly detailed that I'm not entirely sure we're actually going to get questions for once, which is a testimony to you really more than anything, because you were covered so much and so well that people don't have anything left over to ask.
I just want to mention that people are always welcome to reach out. If questions pop up later, they can reach me via my Twitter account or otherwise via email. That's always fine.
Oh, wonderful, wonderful. Yeah, so available on Twitter. You probably saw that Dr. Avest did retweet us earlier as well if you do follow us on Twitter, so you can find them through that. Someone has actually popped a question in, just anonymous attendee. Thank you for your talk, of course. I will be joining KSS as an F1 next year, and I'm really interested in getting involved with the air ambulance. Is there anyone I could contact to learn more and get involved? So that's going through your contacts down at the London Airambulance.
They can contact me on my Twitter account. I think that's easiest, and if they send me a DM, I can answer the questions there.
Oh, Kirsten. Hello, Kirsten. It's a long time no see. Has put, have you heard of street doctors for prevention charities as well? They were at, I believe Kirsten will probably correct me there, they were at our conference last year, and I believe they're there in Manchester as well, actually. But yeah, a question to you. Well, to reread it. So it's, have you heard of street doctors for prevention charities as well?
No, I haven't. No. I came across the Your Sons initiative as one of the people who founded the initiative. Also worked in the Royal London Hospital, and I think because we talk about a lot of invasive procedures that we can apply to a really small amount of patients that we can potentially save by these procedures. But I think overall, there's many more patients we can save by focusing on good prevention of knife crime and social support of people, and also by learning people how to prevent first aid, because we as EMS providers, we're never there first on scene, and the first few minutes are so super important to treat these patients. So I think in general, any initiatives to teach the general public how they can help in these kind of instances are super important. We as we are asked to help out, to organize these events or to attend or to present on it, I think we should do whenever we can, because I think it just matters.
Yeah, perfect. And there's loads out there. So, there's loads of sort of first responders that are first on scene as well. But in terms of charities, if anyone does want to check any more out, you've got like people like Knife Savers, Oasis, Red Thread, it's like VRU units as well. There's loads around, loads worth checking out and having a look for. And now the questions are coming in, which is lovely to see. It's always one that triggers the rest, and I love that. So Dave has asked, would a feasible option for pre-hospital initial treatment prior to HCP arrival would right lateral abdominal pressure or shift like opposite of left lateral manipulation during maternity resuscitation?
So sorry, can you repeat the question?
Yeah, if you can get the questions up yourself as well, Dr. Terrest, if you want to see them. Sometimes they are written in a bit of a way as well. So, so it's Dave at the top. So would a feasible option for pre-hospital initial treatment prior to HCP arrival would right lateral abdominal pressure or the shift, like opposite of left lateral manipulation? So I think they're basically sort of what are the feasible options?
Yeah. It's a really nice question. I've never thought about that myself, and I don't know if there's any evidence around to support that. I think it would not be the first thing I would try in the patient with an exsanguination hemorrhage from a penetrating injury. But I think it's a nice suggestion. I will definitely dive into literature to look for it.
Perfect. And just I just wanted to bring your attention to the chat. I think you mentioned earlier some of your colleagues might be joining in. They've said hello in the chat to you. So Frank Van Ham and Samai from up in the south of the Netherlands. Oh no, south of the Netherlands, you're North Netherlands, but you have got people on there from the Netherlands saying hello. And Samai actually has asked a question. So within the COMA acronym, sorry, as everyone knows, I'm not a medical professional, so if I pronounce everything completely wrong, it's just because it's not in my verbatim, unfortunately. So ACIs implies the cannulas. However, fluid therapy has changed from just using NACI ringer whenever no blood is available. What fluid therapy do you suggest in pre-hospital setting during traumatic cardiac arrest? No blood transfusions available, and based on what parameters do we make these decisions?
Very good question, because there's been a lot of focus on the pre-hospital administration of blood products. I think blood products really make a difference, but of course they're not always available, and not always available to people first on scene. And then your question is, do you have to give the fluids you have, like the crystalloids, like the normal saline or the ringers, or no fluids at all? And I think when a patient is truly arrested, I think it's probably a good thing to start with some fluids to keep some circulation going, but don't overdo it. If you have to infuse liters and liters of crystalloids, you probably make it worse for the patient, because no oxygen will be carried around by the fluids. But I think maintaining a certain bit of preload may help, especially if an advanced critical care team will arrive later and may be able to give a blood transfusion and perform the procedures we just discussed.
Perfect. Thank you very much. Francesco has asked, thank you for your presentation. I'd like to ask you the following. Would you rely on NIBP in an unstable patient? If not, would you or do you invest pre-hospital time in establishing invasive BP monitoring?
That's two questions and two very short answers. I would not rely on the NIBP in a very unstable patient, because what you see quite often is in these patients, the NIBPs go all over the place. They go from really low to really high to not, and sometimes the machine just keeps cycling. I'm pretty confident that the NIBPs shown are not reliable, and I would go for the clinical signs I described in my presentation to see how the circulation is doing, and I would definitely invest in pre-hospital time establishing invasive monitoring if I'm not around the corner of a hospital, especially when I have to longer transit times in these patients. I would definitely consider it.
Perfect, thank you. Leon asks, thank you very much, Doctor. Just a quick one. How long would we use a rebow in the field? I'm taking in the perspective of me working in a remote site setting.
I think Leon means reboa.
Reboa, yeah.
Yeah. And how long we would use a reboa? A few notes on that, because reboa is not something which we simply put in. It is a technique that you can only use in a well-governed system with continuous training and continuous governance, and even then, it is a procedure that's not taken lightly to do. So there's very few patients we do it in. If you have to do it and you have to make the decision, it's the right patient, the right setting to do it. It will usually takes you 5 to 10 minutes from cannulation to getting the balloon up in the field. So there's not a long time. But the most difficult part of the REBOA is getting the system around it, so you can do it safely, and making the decision which patient need it. It's not the procedure itself that's really difficult.
Thank you, and that showed my lack of knowledge there, as I did promise you it would come out at some point. But so an anonymous attendee has asked, should TXA be an SOP alongside your COMA acronym, as well as minimize scene time?
Yeah, I know TXA is a thing in all exsanguinating hemorrhage patients, but what TXA does, it's an anti-fibrinolytic agent. So it's likely more beneficial in patients who have small vessel diffuse bleedings, like when the pelvic plexus is distorted in pelvic fractures, and likely patients who have major arterial injuries, like a stabbing in the iliac artery, have probably less benefit from TXA. I don't say we should deviate from it. There's definitely a role, and I think we should stick to the protocol and give it. But these patients will likely less benefit than from the blunt injury patient with the distorted pelvic plexus.
Wonderful, thank you. And on the back of the REBOA question is Jen, I'm sorry if I pronounced your name wrong here, Jayanta has put, what do you use to inflate the balloon of REBOA? Just air?
No, water.
Water. There we are, simple. And Brian has asked a question about citizen aid. What about the role of wound packing as taught by citizen aid? I don't know if you know anything about that, but I thought I'd ask it anyway. It is the last question that's in, so just in case.
I'm sorry, I'm not familiar with the citizen aid. As I told you, I live in the Netherlands. I'm practicing here, so I'm not familiar with citizen aid. But can you maybe elaborate a little bit further on that?
Well, what I can actually elaborate a little bit further on that, not from a medical point of view, but from a way to answer your question, Brian, is if you check out the webinar from, I think it was about 3 weeks ago, from Colonel Parker, who talked about improvised first aid. They actually did touch upon this in the webinar. And hopefully, if you rewatch tonight and rewatch that, you should be able to link the two together. So we do have a webinar that Colonel Parker actually touched on citizen aid quite a lot, and wound packing, obviously using improvised first aid and sort of using bizarre things that you have lying around the house. But hopefully that would be able to answer your question a little bit further. If not, obviously citizen aid are available online, and obviously Sir Keith Porter, our own founder, is one of the founders of those guys as well. So drop us an email, and hopefully I can pass it on to Keith as well, who might be able to answer your question once he is back from Malta, I believe is where he is at the moment. So I'll pass that question on for you, Brian, if that's okay. So with that, I believe that is all the questions done. The chat is finished. Thank you so much for your time tonight. All that's left to do is our usual, which is thank the wonderful sponsors who help keep, as well as yourselves as members and watching, even not members, but people who just watch the webinars. It's all you guys, as well as these sponsors, that help Trauma Care keep going, allow us to put on these regional conferences, webinars, and all these various different educational resources that we have available. So first up, we have Galen, who manufacture Penthrox, the first line emergency analgesic. It's about time. Scan the QR code that's on your screen now. They have CPD accredited webinars available talking about administration in the field, the use of different sort of drugs that are out there as well, not just Penthrox, but different ones that they manufacture. So do check those guys out. And I know for a fact they've got some exciting news coming up, so do check them out and check out the exciting news coming up soon. And Icarus, the power of health. So scan the QR code that's on your screen now to go onto Icarus's website and find out more about the work that these guys do all over the world. Such a wonderful and cool, innovative company. We are very proud to have them as one of our sponsors. And QualSafe, one of our newer sponsors. I don't know if the guys are in the audience tonight, but they are one of our newer sponsors. You can go across to qualsafeawards.org. They've got loads of qualifications available on their website, and they have an automated certificate system as well. Wonderful company, really, really big on the first aid front. So they've got loads on that side available. They've just come on board, and we're very, very proud to have them and be our new first aid sponsors. As well as that, we have World Extreme Medicine. Check out the QR code that's on your screen now. Scan that, go across their website. They have loads of conferences, loads of CPD webinars available. They've got a conference coming up in November where I think Sir Keith has been roped in to speak for them. But they are all about trauma in austere environments. They've got practical courses available as well, which they sometimes run in conjunction with Gail and with ATAC, with all these people that we all work together. Really cool company. Check these guys out. and Pro Trainings UK. So on the, again, Brian, back to the first aid front, Citizen Aid are also good with Pro Trainings. They have courses available there as well. So do check out to the website on Pro Trainings UK. Scan the QR code there. There's 1,000,001 different first aid courses there, and they are all CPD accredited as well. And they've got everything from pet first aid all the way through to your advanced AHP stuff. So do check those guys out. And partnered with the University of Wolverhampton as well. So scan the QR code that's on your screen there to go through. I think ACAS is just about to close. However, it's worth checking them out if you've got any children that are wanting to become paramedics like yourselves. And on the flip side of that, the University of Sunderland as well. So very similar, but different sides of the country, but we're also proudly partnered with them. All of their students at the University of Sunderland do have access to free trauma care student membership benefits, as well as access to our books, manuals, all sorts of wonderful things, and a really, really cool campus as well. That is all there is to say from us. So thank you so much, everybody, from joining us from all over the world. I saw Germany, I saw Kenya, I saw obviously the Netherlands as well joining us tonight. Thank you all for joining us wherever you are in the world. Enjoy the rest of your evening, your day. Stay safe, be kind to yourself. Dr. Sarah Avest, thank you so much for joining us and giving us such a thorough, well-researched, well-thought-out webinar. I'm sure, as everyone has put in the chat, it's very informative, amazing webinar, and everyone has learnt a lot. So thank you so much for joining us. Enjoy the rest of your evening all, and good night.